I'm Barb Cochran. I am the director of the Deternier Center for Healthy Aging here in the School of Nursing at the University of Washington, and I'm also an associate director for the Northwest Geriatric Workforce Enhancement Center, which is sponsoring this lecture series. And I wanted to go over a few things, just given that we're starting off the first lecture series today. First of all, these lectures are being provided free of charge. However, if you want to get continuing education credits for the series, there is a process in which you pay a $45 processing fee, and then you can get either a total of 15 contact hours or 1.5 contact hours for each lecture. And your site coordinators should have a sheet that explains what you need to do to register. Basically, the registration for contact hours is through uwcne.org. So that's UWC as in cat, ne.org. That's where you sign up for contact hours. If you don't have the sheet, which looks kind of like, well, you're not going to be able to see it, but it's a one-page sheet about continuing education, please don't hesitate to contact your site coordinators, or you can contact us at nwgwec@uw.edu. That's our email address, and we can send that information to you. The other thing I want to mention is that these lectures will be posted on our center's website within a week of their being presented. They're available on that website for free, and that website address is nwgwec.org. So again, that's nwgwec.org, and just look for the Educational Opportunities link, and you'll see the Geriatric Healthcare series, along with about 70 other lectures that have been presented in the past on topics of interest. And with those lectures is included both the video as well as a handout of information. So I think that's all. We're going to try to hold questions to the end, but if you have technical concerns, please use your chat box and let us know that. And I would like to get started introducing our speakers. So Allison Boll and Melissa Ensey are actually involved with the Northwest Geriatric Workforce Enhancement Center as primary care liaisons for their respective AAAs. Allison is you want to raise your hand, is the primary care liaison at Aging and Disability Services, the AAA for Seattle-King County, and she has over 5 years of experience in the aging network and an educational background in social work. Following her undergraduate education, she worked with older adults and families in post-acute and hospice care settings, so a broad base of experience. During her graduate studies at UW, she was trained to implement person-centered practices in the Aging and Disability Network in New York Community Trust Grant. And she's applied this training when she joined ADS in 2014. During her time with the Aging and Disability Services, she's coordinated projects to facilitate expansion of the Information and Assistance Program, and her current role involves bridging geriatric healthcare and social services sectors through outreach, education, and training activities. Melissa Ensey is the primary care liaison, raise it high, representing the AAA Area Agency on Aging and Disabilities for Southwest Washington. So she gets credit for coming all the way up from Vancouver, Washington today. Thank you very much.
Of course.
She received her Bachelor of Arts in Communication Studies from the UW and her Master's of Science in Education in Community Counseling and Student Affairs, Leadership and Practice from Youngstown State University. Where is that?
Youngstown, Ohio.
Oh, okay. Thank you.
Of course.
Melissa has over 11 years of experience in health promotion and community mental health, family caregiver services, and care transitions initiatives, and they both have a wealth of experience to share with you about the role of AAA and disabilities agencies in geriatric healthcare. So which one of you was going to start?
I'll be
Okay.
starting us off, and
All right.
I would just like to start by saying hello and Happy New Year. We are so excited and honored to be able to kick off this whole series, and I really appreciate those who are viewing live across multiple states, as well as those who are here in person today. As we discuss this topic that I think you'll find is very relevant to all of your work and important. We have no disclosures, but do want to express that the views and opinions that we may offer are that of our own and do not necessarily represent the official views of HRSA or the Department of Health and Human Services. Today, by the end of this presentation, you should be able to discuss the role of area agencies on aging and disabilities in helping community-dwelling older adults and caregivers manage their social and clinical needs. You should be able to name some evidence-based programs and approaches that support self-efficacy, positive health outcomes, and quality of care for older adults. And you should be able to explain how family caregivers can be engaged as part of a healthcare team. To that end, we will start by providing some introductions and context for this presentation. Next, we'll provide a foundational overview of area agencies on aging before we launch into really the deep and important part of this presentation, which are the specific roles of area agencies on aging in geriatric healthcare. We'll kind of highlight some themes from those roles and case studies, and we'll close with next steps and take questions at that time. I'll let our IT folks know it seems like people are having a lot of feedback on their end, and I'll just ask, are you connected via Wi-Fi? Probably want to connect via broadband or Ethernet cable and make sure your audio is up on your computer.
Okay, so as Barb mentioned, Allison and I have the opportunity to be a part of the Northwest Geriatrics Workforce Enhancement Center in partnership with our local AAA offices, Allison here in King County and myself in Southwest Washington, the AAA down there. And this Northwest Geriatric Workforce Enhancement Center has the goal of enhancing primary care of older adults and family caregivers through enhancement of clinical partnerships as well as community partnerships. And one of the programs and services of the Northwest Geriatrics Workforce Enhancement Center is this lecture series that we get to participate in. So just wanted to give that as an overview, kind of why Allison and I are here. Specifically, we serve as the primary care liaison. So our goal really is to do targeted outreach with healthcare providers to make sure that they're aware of what resources and what services exist in the community that can enhance their patient care. So we want to make sure that providers can meet patients where they're at and can give resources and support and have confidence to be able to refer over to their local AAA and know that those patients are their needs are going to be met, but also to be able to introduce some of the programs in a clinic visit potentially, or maybe it's working with their high-risk case management staff or whoever it may be who's going to be connecting with those patients in the clinical setting. And we really serve as that bridge to say what's going to best meet the needs of the physician or of the healthcare team, and what's going to best meet the needs of that patient in the community, and try to make sure that we aren't siloed ourselves in bridging those two environments. So that's just to give you an overview of Allison and my role and kind of why we're the ones who have this opportunity to come and share more about AAAs in general.
Thank you. And I think that raises a question of why is it important to bridge these two roles? I think Melissa raised great points. And why is this a topic of importance for us to address today? And I'll kind of frame this in the context of social determinants of health. We know that there is a growing body of evidence to support that a majority of health is not necessarily happening in strictly a clinical setting, but it's happening in the home and community. It's happening in the places where we live, work, and recreate. Healthy aging and the ability of individuals to make healthy choices and to self-manage their health and health care are influenced by a variety of factors that are represented on the graph in this slide. Socioeconomic factors are found to influence up to 40% of an individual's overall health. And that includes education, employment, income, family, social support, safety, and I'll probably also add health literacy. Healthcare, specifically access to healthcare and the quality of healthcare received or clinical care, represents up to 20% of someone's overall health, and health behaviors 30%. And since we're talking about geriatric healthcare in particular, I thought I would raise kind of how these social determinants may impact older adults in particular, interactions across these determinants. For example, an individual with a fixed income, so maybe strictly Social Security, may not have access to healthy foods and may not be able to make decisions that you as providers may see as necessary in order for them to manage their chronic conditions regarding the foods that they eat. They may not have stable housing, may not be able to pay their utility bills and their rent. Aging-associated diseases and changes in mobility as people age may impact an individual's ability to work, as well as be out in the community, recreate, engage with their family and other social supports, and also get to medical appointments. Action in any one of these areas can influence positive outcomes in another area. Okay, so I'm going to move closer because people are communicating that they're having trouble hearing. So I'll also try to speak a little more loudly. But kind of in summary, understanding the social determinants of health helps us begin to picture what the community role is in optimizing primary care and health outcomes among older adults. And that is why we're here talking about the role of area agencies on aging in the community. We thought it necessary to provide a foundational overview of area agencies on aging. I think you'll find through this presentation and this overview that there are some kind of core aspects of AAAs that are the same across multiple states and multiple regions, but there are also differences, which is why both Melissa and I are here representing our respective area agencies on aging. So we want to be sure that everyone is operating with the same core understanding of area agencies on aging. And I'll also note here that we may use the term patient and client interchangeably, depending on the context in which we're referring to, really because our patients and clients are being mutually served by our respective organizations, area agencies on aging and healthcare entities. Area agencies on aging were nationally established in the 1973 Older Americans Act. And they were really meant to be designated on-the-ground organizations to help older individuals and people with disabilities remain independent and have choice regarding the choice of where the services they receive and where they age in the community. All AAAs play a key role in planning, developing, coordinating, and delivering a wide range of services and supports in their respective areas. So the Older Americans Act, as I stated, is foundational for all AAAs, but it also was intentionally designed to leave enough flexibility for services to be tailored to a respective community. So our local delivery systems are what we call aging networks. When you hear someone say the aging network, what you see represented on this slide is what we're referring to. The Federal Administration on Aging provides oversight of the network and funds state units on aging. State units on aging then oversee and fund local area agencies on aging in their respective service areas. Now, a service area could be anywhere from one to several counties. My area agency on aging represents one county, King County, and Melissa's oversees services across 5 counties. Local area agencies on aging may be direct service providers of services like case management, but most AAAs also contract with local service providers to offer direct services such as meals, transportation, information, and assistance. And the key takeaway here really is that every local network may look different, but there are over 600 AAAs serving nearly every local community across our nation. In addition to those direct service providers in the aging network, local networks include other layers of support that help individuals remain in their communities of their choice. So individuals may be engaging with multiple of the entities represented here at any one time. For example, an individual who maybe recently was discharged from a hospital may require transportation to get to a follow-up appointment with their primary care provider. Even during that time, they may also be engaging with the state agency and area agency on aging to apply for Medicaid long-term care services. So our philosophy is to engage and partner with anyone who plays a key role in our clients' lives, and we understand that this enhances the work that each one of us does. So to this end, we form informal and formal financial partnerships with other entities. The most common here are represented on this list. And we do that for the purposes of pulse checking, so getting a sense of what's happening in the communities, communication, information sharing, and coordination of services.
So, as Allison shared, the Older Americans Act is foundational for the services that AAAs provide. And the Older Americans Act targets older adults who are over the age of 60 and their caregivers, and paying particular focus to individuals who maybe are low income. That can include individuals who are at risk for spend down for Medicaid, but maybe aren't Medicaid eligible at this time. Older adults who are living in rural areas or who are socially isolated, ethnic, cultural minorities, those with limited English proficiency, as well as individuals at risk of institutionalization. And I think across the board through the aging network, that key component of individuals at risk of institutionalization, especially those if that's not where they would choose to age in place, we want to make sure that the Older Americans Act and the services that the local AAA is providing an alternative for those older adults. And currently, Older Americans Act services reach 1 in 5 older adults. However, next slide. Thanks. Most AAAs are serving adults under the age of 60 as well. So those could be individuals living with a disability or with a chronic illness, as well as caregivers. So caregivers of all ages, as we all know that there's no set age limit for when you become a caregiver for someone that you love. Veteran services can be another component of a local AAA, and then just others. And so we leverage other funds or those partnerships that Allison was speaking of to make sure that we're meeting the needs of a broad range of consumers. So just because someone reaches the age of 60 doesn't necessarily mean that they suddenly need the services offered by a AAA, and vice versa. Just because someone is under the age of 60 doesn't mean that they couldn't benefit from a service provided through their local AAA. And again, this is going to look different depending on your local area. But this is where we would see a lot of overlap with healthcare, is this idea that we serve a broad range of consumers, not just those who are over the age of 60. So every AAA is going to look different. However, every AAA who's receiving Older Americans Act funding is going to have certain core services. So as you're looking at your local aging network and thinking about reaching out to your local AAA, these are the 5 core services that you'll find across the board for any AAA that's receiving that funding. So elder rights programs, so this includes detection and prevention, as well as increasing awareness of elder rights and elder abuse. So this may be represented locally by a long-term care ombudsman program, which those are advocates who are in place who are designed to make sure that the needs of older adults who are living in an institutional setting are being met. So can they mediate between the family and between the institution? Can they make sure that that person who's living there they're feeling like they're being treated fairly? So elder rights, abuse, and prevention is going to be a component of every AAA, as well as caregiver support. So AAAs recognize the demands, the huge demands that are placed on family caregivers and caring for a loved one. And we want to make sure that those caregivers are connected to programs and services that are going to allow them to continue to provide that necessary care, but that also that they learn how to care for themselves and care for their own needs, and that they get into programs and services so that their own health isn't sacrificed by serving in that family caregiver role. Nutrition programs. So most often this is referred to as Meals on Wheels or congregate meal sites, but foundationally, the Older Americans Act wants to make sure that older adults have access to healthy food and healthy nutrition, and whether that's in a social setting where they go somewhere and they receive those meals, or they're receiving their meals delivered to their home. And again, how those services are carried out is going to look really different depending on where you're at. And every AAA will offer a health and wellness related programming, so that's promotion of healthy lifestyles, physical activity, making sure that older adults have access to health screening or education, that they're finding ways to integrate physical health into their day-to-day lives. And then supportive services. So these are those services that are going to make sure that older adults can maintain their independence as long as possible in the safest way possible. So that may be transportation or in-home care or contracting with an adult daycare, or as well as information and assistance. And we're going to go into a little more detail about many of these programs or services, but we felt it was really important to know that as you're reaching out to your local AAA, what these programs are going to look like may be different. However, you can look for these 5 core services.
Thank you, Melissa. So while the AAA provides those set of core services under the Older Americans Act, they also engage in a pretty lengthy planning process to tailor specific services to the needs of their service area and their local communities. So this begins with community engagement and stakeholder feedback, so also feedback from community health needs assessments that have been conducted by hospitals, direct feedback from providers, service providers, and healthcare providers. And then once they've identified the services that are in the most need, they develop plans of action called area plans on aging. Then they contract for and directly provide the services. So engaging in that kind of bottom-up planning allows AAAs to kind of create a broad range of support that then an individual living in the community can select and tailor their plan of care from. Through this planning process, we have found that a majority of older adults prefer and like to receive information from their healthcare providers about community resources. And they also increasingly say that one of the core or top concerns for healthy aging in the community is their health and health care. So in order for us to fulfill our mission, we really do need to collaborate closely with healthcare providers in order to keep individuals living well and with dignity and choice in their community. So in the majority of this lecture, we'll be talking about the specific roles that area agencies on aging play in geriatric healthcare. And we most likely won't be talking about any one specific program at a time, but these are roles that cut across most of our programs and span a lot of what the core services that Melissa kind of described in detail. So Melissa kind of mentioned information and assistance, and I'll begin by talking about the Area Agency on Aging role as a focal point, an assister, and an assessor. Earlier, we discussed the interactions across social determinants of health and the factors of healthy aging. And for providers, what this means is you often have to tease out some of the underlying issues and then decide what kind of your area of focus is going to be, what kind of presents maybe the greatest risk, and what the goals of that patient are, and then translate that into available community resources. And this is often happening in a limited time frame. And there's a feeling that you may not want to broach a certain conversation if there's a sense that there isn't a community resource available. And from the patient and family member perspective, managing several health and socioeconomic issues that we talked about can become overwhelming really fast. They may wait for their healthcare provider to start a conversation, to introduce a community resource. And once those resources are introduced and discussed, they may feel too overwhelmed to track and follow up on that resource. So AAAs and our role in this scenario is that we can act as connectors and portals of care for patients, family members, and also providers by offering objective information about services. And we can also identify appropriate programs and assist people navigating and applying and enrolling in those programs. And those partnerships that we mentioned before are partnerships that we leverage in order to coordinate eligibility screening, referrals, and warm handovers across providers. Now, this may be phone-based, so typically every area agency on aging has a toll-free number that anyone can call with questions and to get assistance. But it also can be as in-depth as an in-person one-on-one visit to discuss really what someone's needs and preferences are, maybe what barriers they've been experiencing to accessing services and assistance filling out applications. So really a key takeaway here is that providers or individuals calling for themselves or another person don't need to know necessarily what it is that they're asking for, and we find that our staff are often fielding calls where someone's calling and don't really have a specific request. They're not specifically requesting one community resource, but our staff are trained to really kind of get a sense of the full picture of the person, their needs, their strengths, their challenges, and tailor kind of a plan of care for that person and translate information into a community setting. We also engage in follow-up as part of that to monitor the efficacy of the services that were recommended or that we directly connected a person to. So this ensures that in any moment of time, someone's receiving the best fit of service for them and their current goals of care. One of the key benefits of this is that we're able to get upstream from issues that may cause poor health outcomes down the road. So a common scenario is that someone is calling for a utility disconnection, or maybe they foresee that they're going to have difficulty paying a utility bill this month. But through conversation with Area Agency on Aging staff, they may uncover that that's also impacting someone's ability to access nutrition, and maybe they also need transportation fare or assistance to get to an appointment or to get to another community setting or even a grocery store. So someone also doesn't need necessarily to wait until there's an acute need or crisis like that scenario that I presented, but anyone can call because they're interested in understanding social activities, fitness classes, or training to re-enter the workforce. So this role could be as brief as one call, 2 calls, and follow-up, but is typically reoccurring and ongoing, and we find that people call over time, or as we continue to re-engage them, that we learn something new about them and are able to tailor the current services that they're receiving to really kind of what is the right size fit for them at that moment in time, the right place, the right provider, and the right service. Another role that area agencies on aging play, and that someone may get connected to through information and assistance or directly from their healthcare provider, is health promotion and self-management. Because as AAAs, we've seen that the effect of chronic conditions, and increasingly multiple chronic conditions, on the ability of our clients to age in place. So AAAs have now at the forefront of developing, adopting, or expanding evidence-based health promotion programs. Most of these programs are offered in collaboration with community settings like meal sites, senior centers, and also healthcare providers. So they might be held at a hospital or a primary care clinic. But nearly all AAAs deliver at least one program with a result in self-management, education, disease prevention, physical activity, or falls prevention. I've highlighted some programs here. I understand that this is a lot of information, but I want you to be able to take it after the presentation or do some research. But these are programs that can be found across many of the areas that individuals are viewing from. And so I'll kind of briefly provide an overview of these programs, but at the end of the presentation we'll have a resource slide so you can look up, the evidence behind these programs and where they're offered in your local community. So the first program represented here is Enhanced Fitness. And Enhanced Fitness was developed at the University of Washington and is an exercise program that combines balance training, strength training, and cardiovascular training to prevent functional decline in older adults. It's designed for any older adult who wants to maintain or improve their physical function and can also be tailored to a specific participant's fitness level. So while it could reach a general older population, it could also meet the needs of someone managing a chronic condition such as arthritis. Participants of this program have seen an increase in their overall functional fitness and well-being, and also decreased healthcare costs and utilization as a result of receiving this intervention. Matter of Balance was developed at the Boston University and is designed to reduce the fear of falling and increase activity among older adults. It's designed specifically for older adults who maybe have had fears of falling, experienced falls in the past, and as a result of those falls have restricted their activities. So maybe they're no longer going out and socializing. Maybe they are fearful of going to the grocery store. So in this program participants learn to view falls as controllable and manageable, and they're able to set goals for increasing their activity and make changes either in their environment or in their lifestyle, so increasing their exercise for strength and balance. As a result of completing this intervention, participants have decreased their fall risk, fears of falls. They feel more able to address falls and make changes. They increase their physical activity and as a result have seen a decrease in ER visits and hospitalizations. Living Well with Chronic Conditions is a Stanford suite of programs. So this is one that may be recognizable across most participants in this webinar. It was developed by a team at Stanford University and is a self-management education workshop for any adult with a chronic condition. So this program aims to build an individual's confidence in managing chronic conditions and could be particularly beneficial for individuals managing multiple chronic conditions. And I'll talk about this program more in depth in a case study, but this program is one that is more so than others offered in the healthcare setting or in collaboration with healthcare providers. So you may find this offered at a hospital or a primary care clinic, and if not, there's certainly opportunity to work with your AAA to bring this to your patient population. Powerful Tools for Caregivers was based off of the Living Well program, and this is a self-care education and self-management workshop designed to help family caregivers manage the stress and burden of caregiving and feel more effective in their caregiving role. All of these programs have demonstrated improved health status across several variables that we mentioned here, including pain, social activity, depression, health distress, and illness. And it's also improved health behaviors, so participants have now engaged more closely with their primary care provider, communicating more often with their primary care provider, and are exercising or becoming more physically active or integrating in that to their daily activities. But we also see a system impact as a result of these programs. So people are experiencing fewer hospitalizations, fewer ER visits. There's a reduction in utilization of high-cost healthcare. And other themes that you'll see across these is this social benefit. So many of these are small group activities, so people are able to socialize with their peers and get peer support in setting goals and problem-solving barriers, maybe to continuing participation, or how do you, when they apply their learning inside the home, maybe there's a barrier and they need to revisit the goal, and their peers certainly help them do that.
I've even seen situations where groups will continue to meet after the intervention is done, or groups of family caregivers will kind of do an ongoing support beyond the powerful tools for caregivers. So I think that that social piece is actually a big component for a lot of these older adults that is ongoing, an ongoing benefit.
And another benefit of these programs is because they're offered in community settings, they may be a primer for other services. So for someone who maybe doesn't necessarily see themselves as a participant in a senior center, or maybe kind of resistant to going to some of those settings because they don't see themselves as a senior or an older individual, these may kind of break the ice, so to speak, and those community settings may act as kind of a focal point or a connector to the aging network. So there are opportunities to build these programs into a plan of care, and certainly if they're offered in partnership with healthcare providers, you're able to tailor it to a specific patient population, such as those experiencing chronic pain, for example. We talked about that information and assistance role, and we mentioned that it could be brief, but is often reoccurring. And more in depth than that role is the AAA role in care coordination and management, because we've seen an increase in the acuity of the cases that we're managing, and people are often managing multiple social, behavioral health, and physical health issues at one time. So care coordination and case management allows us to support an individual who are facing several issues at one time and don't necessarily have other support systems in place. So care coordination case management often consists of a social worker who conducts an in-home assessment and then works with a caregiver, that individual, and providers to create a service plan and implement that service plan. And they often coordinate across providers such as the hospital, primary care, and pharmacists in order to tailor a service plan that also acknowledges the care plan goals and the training and education that's being received by a healthcare provider. So they're able to reinforce the training offered by healthcare providers and increase someone's engagement in managing their healthcare. What I will say about care coordination and management is that this in particular is a role that will look different across all area agencies on aging. It could be a state level initiative, such as the Medicaid case management or in-home personal care. COPES may be the waiver program that folks on this webinar are more familiar with, but it could also be an area agency on aging level initiative. It could reach, kind of expand the folks that we reach to not just be that Medicaid population, but also capture people pre-Medicaid. It could be more short-term or long-term. So this is really a service that looks different across each AAA, and we'll tell you how you might engage with your AAA and learn what really exists in your community.
But this could be a specific opportunity to jump in and to contact that local AAA to say, what do you offer? Over 80% of AAAs in the U.S. offer something that falls under other case management services. So do they have a care coordination program that maybe they don't refer to as care coordination, maybe they refer to it as case management, but reaching out and finding out what your local organization offers, I think would be a great opportunity to start a conversation. And I think that this program in particular, care coordination and case management, is where there's a lot of overlap with healthcare, because most of what these care coordinators are doing and what these case managers are doing is work to reinforce the goals of care in the home setting. So we have an opportunity through the grant where we work with residents who get to go on home visits, and they get to go see the work that the local AAA is doing. And through that work, we had a resident who went out with one of our care coordinators, and you could see that it all clicked, that the work that that care coordinator is doing when they're meeting with that patient, client on a monthly basis is really to enhance the goal of care, to the point that they actually went and visited with a client who that care coordinator had been at the clinic visit the month prior with that same provider. So for that provider to see in the home setting that the sole purpose of that visit was to talk about and revisit what the provider had already shared, if that makes sense. So the care coordinator was trying to make sure that the goals of care were being translated to the home setting. And so in the clinic we talked about X, Y, or Z, how's that working, or how's that looking on the day-to-day. And so I think that this is really an opportunity where we want to make sure as a AAA that the work that we're doing is working in alignment with that healthcare team and to be a part of the healthcare team. So with that, one of the things that AAAs are really well positioned to do is to translate those patient health goals from the clinical to the community context. So most AAAs do a lot of home visits. So we are working with those patients, those clients in their community, in their home setting, and we're looking at that patient's care plan in the context of their home environment to say, how can we get this person connected to community resources? How can we get them more engaged or more involved in their own plan of care? How can we work upstream to make sure that that person's ability to age in place isn't necessarily only being met when we're in crisis mode, like Allison was saying, where my utilities are going to be shut off, but what can we plan for in the future, or what services or supports can we put in place now that we know is going to benefit that person over time, and helping that individual to feel like they're really invested in their care on an ongoing basis. So thinking about an activation of a client's motivation to change, the example that always comes to my mind is someone who's maybe not following a diabetic diet. So as a AAA, we may be going into that home and saying, do you have money for food at the end of the month? So is it a matter of that they don't understand what that diabetic diet means? So is it a health literacy issue, and how can we remove those barriers? Or do they not have access to healthy food because they don't have access to transportation? Or are they not exercising because they don't know how? Or is it because they don't live in a safe home environment, and maybe it's someone who's living and experiencing a hoarding issue, and that's never come up in the clinic because of their own insecurity with it, or because there wasn't time, or just the right question wasn't asked at the right time. And so AAAs are really well positioned to be able to go into that home environment and say, okay, let's look at and let's see what is the whole picture to say where can we start? Like, what's that little nugget that we can latch onto and then grow from there? Because we really want to make sure that a person isn't necessarily having to choose between paying for gas to get to their diabetes self-management class or their next doctor's visit. So if there's ways that we can help to mitigate those barriers or remove barriers in the context of their home environment, that's really one of the ways that AAAs are just so well positioned to be able to partner with healthcare providers to say, this is what we're seeing in the home environment. I noticed this was in the plan of care. How can we work together? Or that healthcare providers can reach out to their local AAA, to that person's case manager, and say, this is kind of what I'm seeing. How can we collaborate? Can you give me a more full picture? Because I think that things don't always come up for a variety of reasons, but that's something that AAAs have worked really hard to be well positioned to be able to engage in those conversations. One of the ways that we do that is by collaborating with family caregivers. As I mentioned earlier, one of the 5 core services of the Older Americans Act is to engage family caregivers to make sure that they're involved and that they feel supported. And one of the ways that we do that is by seeing family caregivers as a part of the healthcare team, that we want to help them to feel confident in their role as a family caregiver. I mean, some of these family caregivers are being asked to provide tasks that people who have medical training may not feel comfortable providing, and they're doing it for a loved one. And so you add in all the layers of the relationship and what has that looked like over time. And so we really take a no one-size-fits-all approach. So where is this caregiver at on their journey? Not all caregivers identify as a caregiver. They say, oh, well, I'm just a wife, or I'm just a son taking care of my parents, or whatever, however they self-identify within that. And so we want to help to see where that person's at in their journey and their identity, and then do what we can to enhance that role. So is there a way that we can work with that caregiver to help them know what to expect as their loved one's diagnosis progresses? So is there conversations that we can have with them on the front side to plan for what's going to happen in 6 weeks, 6 months, or 6 years? We want to make sure that that caregiver feels supported in having those conversations. Beyond that, we also want to make sure that the caregiver has a way to care for themselves and encouraging self-care. We all are aware that caregivers will oftentimes neglect to care for their own needs because they're busy caring for their loved ones' needs. A recent study showed that caregivers who are caring for someone with dementia, their healthcare needs tend to cost $4,000+ more per year, and the biggest predictor of the increased healthcare costs for that caregiver was rating their own health as poor or fair. So we can see that there's a connection there, that caregivers who are not caring for their own needs tend to experience worse health outcomes over time, which can then be translated to think that not only will that caregiver experience negative health outcomes, but their loved one will as well. So we want to make sure that there's services and supports in place that allow for that caregiver to do that. And we also, with that no one-size-fits-all approach, we want to recognize that caregiving is more than just tasks, that relationship is a component. So is that something that we can assist with? Some caregiver programs will implement counseling or things like powerful tools for caregivers, which really takes a good look at how is the relationship affected by this caregiving role and this caregiving identity. So AAAs we spend a lot of time and energy making sure that the needs of the caregiver are met as well. Through the Family Caregiver Support Program, this can include anything from information and assistance. So as Allison was talking about, the call center has different names depending on where you're at. But where a family caregiver, maybe it's just calling for a resource, or maybe they don't really know what they're calling for, but they call because they want to know if there's a provider who does diabetic foot care in the home. And that's what their need is at that time, and that's great, and we can provide that resource. But then they also know that we're here the next time, that maybe their needs are more extensive the next time they call. Here locally in Washington State, we utilize a program called T-Care, which is an evidence-based model and assessment for family caregivers, and it really takes into account some of those components I was speaking about, where it's looking at the objective burden. So is it the day-to-day? Is it the tasks? Is it the relationship? Is it the family caregiver's own depression that's affecting their ability to provide care? And look at those things and get things in place. So is it a support group that's going to be helpful? Is it counseling? Is it access to respite? Do they just need a break because they're providing 24/7 care? We want to make sure that as their loved one changes over time, the needs also are met and changed. So family caregiver specialists work really closely with those family caregivers because what their needs are in the beginning, maybe it's just advice on using supplies and equipment, to a year down the road, it's what supplies and equipment are out there for this new thing which has popped up. So AAAs really want to be that information source, not only for patients, but also for the family members who are helping them.
I will also say that as providers, one thing that you can do is to work with the caregiver to understand what the trajectory of the person they're caring for's disease may look like over time. A lot of what we mentioned is, tailoring services over time for the caregiver, working with them on an ongoing basis, revisiting issues. And so it's also important for them to hear feedback from the primary care provider of the person they're caring for on what that is going to look like. What can they expect? What maybe can they anticipate, so that we can kind of think about the future, advanced planning, conversations around safety, legal issues, financial issues. And this is particularly, I think, salient in cases of Alzheimer's disease and dementia, where these conversations need to occur early on. So early engagement is important, and there are resources and support available in the community for caregivers assisting someone with memory loss.
Another program or service that many AAAs are offering is programs related to transitions of care. So this can be support of a transition from one care setting to another. So it may be from the hospital to home, skilled nursing facility to home. It really depends on the local AAA, how extensive their services are, and what sorts of partnerships are already in place, because many healthcare entities are creating care transitions programs, and AAAs have been creating and working to build up these programs right alongside, and have been doing it for quite some time. A statistic from N4A says that nearly 70% of AAAs offer some sort of program to facilitate movement from an institutional or a hospital, an acute care setting, to a community setting. So knowing that AAAs are there and that we're doing this work, and we've been doing this work to make sure that patients have access to services that support a safe and healthy discharge to home. So, for example, some AAAs will use what's called a care transitions intervention. That's an evidence-based model that looks at things like the 4 pillars. So MedRec, red flags, do they have follow-up, and provide ongoing support for about 30 days. Or the bridge model of transitional care is another one that's social worker-led, looks at biopsychosocial factors, communicating across the clinical setting. And I think that also looking at this as a way of supportive decision-making and long-term options. So it's not just we take a deep dive and look and say, okay, what is the reason for potential rehospitalization, but also what's going to benefit this person in the long term. So this 30 days or 45 days or 60 days, it really depends on what AAA you're looking at. This intervention is going to be here, but when that goes away, how are we going to make sure that this patient is safe and healthy and has access to the health care that they need on an ongoing basis? So again, the AAA, because we work hard to have our pulse on the our fingers on the pulse of what's going on in the community, we may know that there's a resource that exists, that this one person just keeps readmitting, falling through the cracks because they don't have access to a medication. We can help with that. Or maybe it's that they get all the paperwork for that Medicaid long-term care application, but there's a barrier to filling it out or getting the supportive documentation in, or whatever it may be. So oftentimes the goals of these care transitions programs is to prevent unnecessary rehospitalization and to enhance safe discharge, but it's really to look for long-term programs and services that are going to keep that person out of the hospital at day 31 or at day 62, or whatever it may be. So we're going to transition into some case studies to kind of highlight and give an overview of some of the programs and go a little bit deeper into some of the programs and services that we've talked about. So this first one, 59-year-old male who has a diagnosis of hypertension, HIV-2, anxiety, depression, dementia, acute kidney failure, neuropathy, and glaucoma. So when we got the referral from his PCP, it stated that the patient was in process of applying for SSI and has a disability determination services appointment tomorrow, but the patient is concerned about the caseworker's reliability. And we had actually received another referral for this gentleman in the month prior, and from that previous referral, the patient had declined any assistance except for mailed documentation. So we had mailed out the information, but when we called on this second time, the INA specialist learned that the patient had been experiencing increased symptoms of depression, and that they just hadn't been able to follow up or follow through on filling out the paperwork or to get the applications in that they needed. And so we were able to actually, in this case, over the phone, help with getting that long-term care application completed, help with getting it sent in, and the supporting documentation that needed to be provided also sent in. And the patient is now receiving those long-term services and supports, including personal care, medication management, diabetic foot care, and the patient is more engaged in managing their own symptoms. And so I think that this highlights that whole idea that it's asking the right questions at the right time and refer. So this patient wasn't open, or that just didn't resonate with them to accept the service or accept the assistance the first time that they connected with us, but that second time that we were able to connect with them, maybe they were more comfortable or they were more able to engage in those services. And so I say this a lot in my outreach, but making sure that, or knowing that that patient may not hear it or may not be ready the first time that they get connected with their local AAA, but we will still be here the next time that we're able to connect with them. So this,
I wanted to address one question that I saw. I think it's important for the context of this whole presentation. Sorry for interrupting. Someone asked if someone needs to be on a Medicaid waiver to receive these services. And most of the services through the Older Americans Act, which is really the foundation of all area agencies on aging, do not require someone to be on a Medicaid waiver. They're really meant to reach all older individuals and adults with disabilities. There's not typically a financial means testing or screening, though there may be some participation fee or cost sharing involved for some programs. Some AAAs do offer directly the Medicaid case management and play that role, but the core services that we're talking about more broadly are that of the Older Americans Act and really are meant to reach anyone over the age of 60, as well as some individuals with disabilities under the age of 60.
Or in this case, family caregivers.
Yeah, and family caregivers. And I also see a question right here about what an INA specialist is. So some AAAs call kind of that frontline staff that answer the phone, answer the questions, and help people, INA specialists or information and assistance specialists. They may also be called advocates or staff in this case. Thank you.
No worries.
I wasn't sure if this is time to answer questions.
We're gonna have questions.
I just answered a couple. Yeah, I answered a couple that I thought seems really critical for the case studies.
Yeah. So in this case study, a caregiver, we'll call her Cheryl, is caring for her husband, who we call a care receiver or CR, who had experienced a stroke 4 years ago. And the caregiver was only utilizing intermittent services. So occasionally purchasing supplies or attending support groups, but it wasn't necessarily case management or a service on an ongoing basis. The care receiver received a diagnosis of vascular dementia, and after that experienced decreased ability to care for himself and is needing increased assistance with eating or repositioning, and is now using home oxygen and has limited communication. So the caregiver had a strong value in providing care in the home and actually promised to care for her husband as long as possible in the home. but she no longer felt confident in her ability to manage her husband's personal care needs. And they also have a teenage son. And in this instance, the teenage son had begun to exhibit behavioral and emotional struggles as well. So in this scenario, the case manager worked with the caregiver to create a new care plan at the home. So we worked to get her more connected to respite and counseling and caregiver training and ongoing support groups. So her caregiver journey had changed. So she needed more enhanced services than just the supplies or intermittent support. So through that, the caregiver experienced increased self-efficacy. So as I stated, the husband's disease process changed, and so the caregiver was able to adapt to those needs as well. And then increased caregiver self-management of her own psychosocial and physical health needs. So through engaging in things like caregiver training, which would allow her to meet her own needs. And then the care receiver's personal care needs continue to be met in the home, delaying the need for that institutional long-term care. And in this instance, she was also, our family caregiver support specialist went above and beyond, actually was able to get the teenage son connected to some services and supports as well. So this kind of, to me, addresses that idea that needs that impact the caregiver's ability to provide care may not come up in a clinic visit. So when they're there talking about the husband's limited communication or needing assistance with repositioning, it may not come up that one of the big stressors for her ability to continue to provide care is the needs of her teenage son, or that she's not getting time for herself, or that she doesn't feel confident. And I think family caregivers especially sometimes are afraid to share their own shortcomings because they're afraid of what that will mean for their loved one or their ability to continue to provide ongoing care. And so this just demonstrates that we're able to sometimes have bigger conversations with family caregivers and care receivers outside of the context of the clinic, and to try to work to get them connected to services and supports.
So this next case study is related to the evidence-based health promotion programs that we reviewed earlier. And this particular case is in regards to a 68-year-old female with a diagnosis of osteoarthritis, diabetes, and depression. And mostly probably due to the pain associated with osteoarthritis as well as the depression, she was limiting physical and social activity due to the pain. And in the area where this case took place, there was a chronic disease self-management workshop offered in coordination between the Area Agency on Aging and the hospital. So there was a chronic pain workshop there on site in the clinic, and that patients who experienced chronic pain were referred to by the healthcare providers. And in this workshop, with a small group, the patient was able to learn techniques to deal with her chronic pain. So techniques such as exercise, appropriate use of medication, healthy eating, but she was also able to work with her peers for decision making and problem solving. But this particular patient really found that she appreciated the ability to create action plans and goal setting, and working with her peers was a key part in experiencing success with that. But she also found that she became more engaged in evaluating her treatment and decision-making around medication. So she felt like she was able to better engage in conversations with her primary care provider about the medications that she was on, and really decide, what was working best for her at that time, in combination with other techniques that she learned to deal with chronic pain. And there's a quote here from this patient that I found striking, and it's, since participating in this workshop, she's now more active. She likes setting action plans, and she would sometimes set goals that were unreachable. So we see this a lot where people are managing multiple issues and it seems really undoable, like a long checklist of things they have to do. So learning how to set goals that are attainable and then slowly adding on to that was something that this patient found very valuable in terms of managing her chronic pain. And I liked this case because I thought it really demonstrated the partnerships and the value of partnering with healthcare providers and AAAs and bridging that because this person may not have known about this service if it was not offered there in the clinic, and the provider may not have been aware of it as well. And it was able to really be integrated as part of her care plan as a result of that. And this also, I think, highlights the general outcomes that we talked about earlier associated with those health promotion and disease prevention programs, as they're able to impact physical activity, management of depression, management of chronic conditions such as chronic pain, and compliance with clinical care and medication.
So in this case study, we'll call this gentleman Sam, who was a frequent flyer referred to our local AAA from a local hospital. So this was a referral for a care transitions program. This gentleman was diagnosed with heart disease and diabetes, hypertension, kidney failure, and the patient and family were also Spanish speaking. So in this instance, the wife was having difficulty managing his medications due to difficulty reading the medication labels and understanding them in the correct way. And the transitional care, that's the TC part, coordinator met with this patient, his wife, and their two adult daughters. So in this instance, the patient expressed that he didn't want to be a burden on his family. So he was having a difficult time with engaging in any formal services because he didn't want to have his family have to jump through too many hoops in his mind. So the transitional care coordinator was able to review the plan of care and develop and assign different roles for each family member. So it wasn't changing the plan of care. It wasn't saying, okay, you need to do this, even though this wasn't a part of anything that needed to be done. It was breaking down that plan that was developed in the healthcare setting into smaller, more manageable tasks and spreading the workload, which made the patient feel more comfortable because then he didn't necessarily feel like everything was being put onto one person's shoulders, and also made the family feel more comfortable because they had someone there who was making sure that the roles that they were fulfilling were going to meet the needs of the patient. The medications were reviewed and translated for ongoing management, so it seems like something simple, but translation to their preferred language is something that was a big barrier for them, that they just continued to revisit the hospital for prior. And they also filled out that application to long-term care services, and one of the daughters is now the paid caregiver. So through that, the client's feeling of burden on his family was significantly decreased because he felt like his daughter was being fairly compensated for providing the assistance that he was needing. And after this, this patient didn't experience any readmissions for over 3 months, which is a success when you consider that before that he had gotten that frequent flyer label. So we were able to work with him over time, so increasing their comfort with understanding what it meant to apply to long-term care, or increasing their comfort in not being a burden, and translating some of those goals from the clinical setting into the context of that person's day-to-day life. And it was a success.
So putting it all together, I know we didn't go too in-depth about specific programs or eligibility requirements, but rather we talked about roles that span multiple programs, services, and resources. And really, that's because all of those programs and services work together to optimize health outcomes, quality of life, and the ability of older adults, people with disabilities, and caregivers to remain in the community of their choice. And I liked this slide, and I borrowed it from a presentation that I'd seen, and a source is listed here, but I liked it because I think it really highlighted that connection with an aging network and the Area Agency on Aging isn't just kind of one program. One program's not going to do it all, but rather you should think about this connection as one with a range of supports that throughout the lifespan may be beneficial to someone. And these programs work together, and they also supplement the clinical interventions and pharmacologic interventions that may be applied in the clinical setting in geriatric healthcare. So you're able to see kind of the health and the system impacts of the programs listed here that are offered by the Federal Administration for Community Living, state aging and disability services, and community-based aging and disability organizations, including area agencies on aging and our partners in the community. So I see a lot of questions coming in about finding your local AAAs and what's available in your communities. And the federal resource is called National Elder Care Locator. And so this is a toll-free hotline as well as a website that helps consumers and anyone really interested in knowing what's near them to locate the local resources. So I included a screenshot here from one of the other states' viewing. And so you're able to see that they highlight the area agency on aging, so the entity providing that function. And I did see a question about, I can't find an area agency on aging. It's called State Department on Aging. And that is true, that not every area agency on aging goes by that name. Sometimes area agencies on aging are in a county office. So it might be County Office on Aging Disability Services, but they also might be nonprofits. So they might be called Senior Services, Senior Resources, Aging and Disability Resources. So this website can be helpful in locating that specific agency that's providing that function, as well as other key agencies that provide functions for adult protective services, the Long-Term Care Ombudsman, and State Health Insurance Assistance Program. Those might be fulfilled by the AAA, but not in every case. So again, there are exceptions and it can be really complex, but resources like this can help you sift through and locate those key referrals that you might want to make. And I will note that even if you've made a referral to an area agency on aging, if you suspect neglect, abuse, or exploitation of an adult, many of you are still mandated reporters and must report to Adult Protective Services. So a referral to a AAA, down the road we might see a need and make a report ourselves, but you are still also mandated to report to Adult Protective Services.
I always like to say that it can be a both and situation, because a referral to APS may absolutely be in order. However, they may not have all the information they need to take action, and so if the AAA can get involved and begin getting services and supports in place in conjunction with the local APS, that is always a win.
Yeah, so again, AAAs are a best kind of first point of contact, but they shouldn't necessarily be where you stop. But we have a lot of connections with other entities, including APS, and coordinate closely with them. But I want you to be mindful so that you might begin to introduce these as appropriate to patients and their family members and other colleagues that you interact with. So that is a resource that you can either use yourself if you're curious, or that you may refer for patients or family members to access and do some of their own research if they prefer to be hands-on about the tools and resources that they connect with. But you may also make a referral directly to area agencies on aging for patients that you see. Every AAA may have some established process or mechanism for receiving and responding to referrals from healthcare providers in particular. So this could be phone-based, it could be via secure email, or could be via a fax form or a fillable form. It may include follow-up regarding outcomes, or may stop at the referral. I think a good rule of thumb is always to establish patient consent, even if you have a data sharing or information sharing agreement in place with an area agency on aging, because patients need to know that their information is being shared for the purposes of coordinating services, and they need to know who's contacting them. So is it an information assistance specialist contacting them, an advocate, an area agency on aging staff person? Some of these terms may be used interchangeably, but you can let them know as a result of this presentation that their area agency on aging is the trusted local resource in the community for these services and may follow up on a referral that you made. After you establish patient consent, you can visit that Elder Care Locator website and identify the local website or information number, so that toll-free number. That's the information number most likely that AAAs will be receiving referrals from. But you may also seek to call the AAA office or work through an established point of contact that you've made at the AAA. Some AAAs might have liaison roles like myself and Melissa, and you can work closely with them on identifying what the process is for making a referral, maybe creating a new process that really helps us all serve our mutual clients. So again, kind of a theme here is it might look different across AAAs, but we are here in wanting to connect because we recognize that we're often serving mutual clients.
Yeah, and so not only is there an opportunity for you to reach out to your local AAA, but a local AAA may be contacting you, and they may already be contacting you and just not identifying as a AAA. It could be a case manager, whatever it may be. But if I can sum it up, if a local AAA is reaching out to you, it's because we want to collaborate to enhance a mutual patient's care. So it may be obtaining a clinical history or answering a question to result in a better patient outcome. So we want to reinforce those values that are expressed at a clinic visit. So if there's a particular health goal that that person really needs to work on, having open communication about what that goal is really important to us as well. Or we want to make sure that patients have access to all the necessary supports in their home. So maybe it's a prescription that we're reaching out for, or to better understand that patient's medications. Or we want to make sure that that patient has all their questions answered. So if we can kind of be the go-between or translate the patient's needs from the clinical or the community to the clinical environment, we will often serve that role. So if we're reaching out to you, it's because we want to collaborate with you for patients. Okay, next slide. And what's on the horizon? So as we all know, we don't totally know what's on the horizon. There's a level of unknown with healthcare, but we do know that there's this shift to value and this opportunity for new partnerships and for bridging these roles. So as healthcare moves towards this value-based payment system, AAAs are really well positioned to be able to provide home and community-based services that impact and come back to that social determinants of health idea. Many AAAs, as we talked about, are already providing transitional care or care coordination and are often the connector to other critical services. So things like transportation, housing, nutrition. So I would just strongly encourage healthcare providers to make sure that as you're building those networks or as you're building the partnerships for those value-based payments, that you would include your local AAA and invite them to the table, because I think there's opportunity there to integrate care, to make sure that the needs of both entities as well as patient outcomes are really being talked about and everyone's sitting at the same table. And I can't say enough for physician champions. So I think Allison feels the same way, is that a person on the inside who can say, hey, there's this resource here, or to be sharing with their peers, is immensely helpful as a AAA when we're doing outreach and when we're looking for opportunities to formally collaborate. So be a physician champion. That's also what's on the horizon as an opportunity.
So here are some resources that we referenced. I think Melissa made reference to N4A, which is really the National Association of all Area Agencies on Aging. It can be a go-to resource. Northwest Geriatric Workforce Enhancement Center, of course, Elder Care Locator, and resources for those evidence-based programs. We want to thank all the participants. We'll now field your questions, but we also want to give a special thanks to N4A for contributing information to the slides, as well as staff who contributed case studies and information.
Thank you. We'll take questions via the chat box from the sites, and while you're getting those put in, I'm going to go back to some of the questions that came across. And Melissa and Allison, if you don't mind, I'm going to go way back. Some of them you've sort of answered, but I'm going to pose them anyway, just in case you think there's more to add. And then I think we have some questions in the room as well. So the AHEC in Anchorage is asking who pays for these services. At senior centers or aging disabilities resource centers, do you need to qualify? You mentioned a little bit about the Medicaid waiver program. You mentioned a little bit about there being a bit of a fee for service at times, but was there anything more you wanted to add about payment for services?
Just that it's really dependent on the scope and level of services that's being provided. Generally, the Older Americans Act, it's a federal act that funds the core services of an area agency on aging and is intended to serve really anyone who fits that priority population categories that we discussed. Though some services, for example, in Family Caregiver Support Program, there may be some costs sharing for respite services, but the information assistance specialists, staff, or advocates will also ask questions about available income or resources for that individual to get a sense of what's most cost effective and appropriate for a specific case. And if someone is financially or functionally eligible for Medicaid, long-term care, and in-home personal care support, we'll connect them to that.
And I think I saw that question come across when we were talking about some of the evidence-based programs, and so oftentimes those are done in collaboration. So it may be offered at a site where the site is offering the room or the location, and then the evidence-based program is funded through a variety of sources. Sometimes it's state funding, sometimes it's grant funding. So it depends.
And we do partner with, and AAAs, I think across multiple states, also partner with healthcare providers and payers to pay for some of the services, including transitions of care. So I also say that helps supplement some of the federal Older Americans Act funding, and we're able then to better tailor services for those patient populations.
Okay. Did you have a question?
Yes. Who can qualify for these services in terms of immigration status?
So because I can speak to King County, because most of our services don't require a financial needs testing, people can choose to remain somewhat anonymous and don't need to necessarily give a lot of information in order to access services. So we work with nonprofits that specifically serve immigrant and refugee populations, probably including undocumented individuals, in order to have their needs met.
So the powerful tools for caregivers, can those be facilitated by conference calls for those who live at remote locations, and is there training for this program?
So the training, there is training for powerful tools for caregivers, and the website is here where you can find out more information on how to become a facilitator for that, and they have different ways of setting up that program. I'm not 100% sure, to be honest, if a phone intervention is available.
There is an online course. It's called something different, not Powerful Tools, but there is an online course that meets kind of the similar needs, so training around self-care and efficacy for caregivers.
Okay, so the slides on services to those under age 60 says percentage of those served. Do those percentages represent just the people who are under age 60? What percentage of the total are those served who are under age 60?
So I believe on the slides, it's the percentage of AAAs that are serving consumers under the age of 60. So for example, consumers with a disability or chronic illness, 73% of AAAs offer programs or services for the individuals who are living with a disability or chronic illness. So I think that's the first part of the question. And then what was the second part of the question?
What percentage of the total are those served who are under age 60? And what percentage of those served represent? It's sort of the same thing.
I think they're asking, of the total percent of individuals we serve, how many are under 60 versus 60. I don't have a percentage off the top of my head, but I could certainly follow up with that information, and someone has our contact information. So if there's,
it would vary by AAA.
It would really vary by AAA, because Older Americans Act initially was only intended to serve individuals 60 and older and their caregivers, and over time we've just grown to recognize that people are aging into and with disabilities, so we've broadened who we serve. Our contact information is there, so if we need more specific information, you can follow up with us.
Yeah.
So the Alzheimer's Resource of Alaska is asking if the networks are nonprofits as well as governmental.
Yes.
Okay. And then I'm going through all these zeros. Will Wyoming participants get information on what is available to us if they go to that elder care locator?
If they go to the elder care locator, if they have difficulties, they can contact us. Maybe sometimes information I'm hoping it gets updated regularly, but if there's an issue or something that's not clear, they can reach out to us.
And Penny, you asked if you can get the fax number to send evaluations back.
So that is specific to me. So work with if you have a site coordinator, you are a site coordinator, they'll receive evaluations.
That was going to be my answer.
and send to, I just don't want to receive all the fax evaluations myself.
Yes.
But Penny,
why not?
I think my phone number, another participant shared that my fax number, so anyone that I reached out to can send them directly to me.
Yeah, and that's who you should be sending your evaluations to, is your site coordinator, the person who sent you out your handouts and that sort of thing. So all of these phone numbers are very specific to who's the site coordinator. Let's see. Okay. So Allison, hello Allison. I wasn't able to connect using my name, but was able. Okay. The Wyoming Center says they can help with resources. There was a Cheyenne, Wyoming site that was asking for where their AAA is. So
Great.
And do we have questions in the room here?
May I ask a question? So I know that you provide some direct services and also contain some health promotion. So I was wondering about the structure of the workforce. Is there how many nurses or social workers, or the structure of the workforce?
So the AAA workforce is going to be really varied where you're at. Some have really robust volunteer networks that are offering some of the services and supports, and others it's a mixture of social workers or nurses, like you were saying. So I don't have the exact numbers off the top of my head, but I know that most offer a mixture of all of those different types of clinicians and providers.
It depends on the program and kind of the depth of what's being provided, because our Medicaid case management program, we do have nurses that consult on the cases, so we're able to kind of get that clinical lens in addition to the social work lens. Programs like the health promotion programs, they may even utilize peers who have them as individuals lived with chronic conditions. But really anyone working in a AAA is receiving specialized training in aging and disability issues. And they approach it from that community-based lens, but also able to bridge in kind of the clinical setting.
I actually have a question that I've not really discussed before, but do you have, how do you help somebody transition between AAAs? In other words, maybe they're in one area and then they move to another. Are you able to share your information given HIPAA requirements and things like that?
Well, in Washington State, we've kind of grown our information assistance program to what's now called Community Living Connections. And we all share now one database. So we're able to really, quickly transfer cases over and information if it's there. We do so also, in other ways as needed. You might have some more.
For example,
too.
if we worked with people who are on Medicaid long-term care and maybe are moving from one area to another.
Or one state.
Or one state to another. So we can help with bridging that gap. So getting someone, because those programs are going to look different depending on the state that they're in. But I know within our state, we'll help with file transfers and making sure that person's services transfer seamlessly. And even in the Family Caregiver support program, we've helped with someone who's moving from one area to another. So we do try to work collaboratively, at least within our state.
Yeah, and we do get consent for information sharing for the purposes of coordinating services and kind of maintaining continuity of care.
Okay. And then I have another question, and that is, what is the buzz among the AAAs, given that the Older Americans Act was recently reauthorized, is there a feeling that that's somewhat safe?
In terms of the future?
In the terms of the near future.
I would say, that we hope that we've demonstrated how, necessary and vital these programs are.
Mm-hmm.
I think sometimes people don't always recognize just how broad the Older Americans Act is, and it encompasses everything from those home delivered meals to transportation to medical appointments and that in-depth care coordination. I would say you never know what is going to happen.
I think that AAAs have worked really hard to diversify our funding streams to make sure that we are well suited for some of these partnerships. And I know that there's the buzz, or there's a push amongst the N4A, the Aging Network, to look for more ways to formally collaborate with managed care, with healthcare organizations. And by formally, I mean financially collaborate, to say we're here and we're enhancing your patient care and we're providing these programs and services. So how can we make sure that the programs and services are sustainable for the long term? So the Older Americans Act is, like we've said, is foundational, but there's so many variables and so many programs and services that offer a lot more depth and add to that foundational piece.
Okay.
I would say we always try to be positive, but if funding doesn't change year to year too, that's why sometimes we have to really prioritize who we're going to serve, and that's why that might change every few years or look so different from AAAs, because we might really have to focus on those at the greatest risk.
Other questions in the room? Other questions out there? I don't see any coming across other than aging and disabilities